The leading cause of death in women may surprise you. In fact, many women don't even know what it is. Ask the average person what poses the greatest threat to women's health, and you'll often hear answers like breast cancer, ovarian cancer, or complications of aging. While these are legitimate concerns, they are not the primary danger. Cardiovascular disease, not cancer, is the #1 killer of women. What makes this especially troubling is not simply how common heart disease is, but how frequently it goes unrecognized. For many women, the warning signs are subtle and easily explained away. Symptoms may be attributed to stress, fatigue, anxiety, menopause, or gastrointestinal problems. This is why countless cardiac events in women are, quite literally, invisible. Cardiovascular disease is often perceived as a man's problem, yet it remains the leading cause of death in women. In the United States, 1 in every 3 female deaths is due to heart disease. More than all cancers combined, the numbers don't lie. 44% of women are unaware that heart disease is their leading health risk. 71% of women never raise heart health concerns with their physicians, assuming their doctor would initiate the discussion if there were a problem. 38% of women report having an episode when they feared something might be wrong with their heart. Yet fewer than half told anyone, and only 1/3 sought medical attention. Women are less likely than men to receive preventive medicine, both before and after a heart attack, and it is even worse in younger women. After a first heart attack, women are more likely than men to die within 1 year, 26% versus 19%. Women age 55 and younger are twice as likely to be misdiagnosed in the emergency room when presenting with heart attack symptoms. Black women experience higher rates of heart disease and mortality, yet frequently receive less aggressive care. These statistics reveal a dangerous reality. Awareness gaps, diagnostic delays, and treatment disparities are not rare, they are systemic. A significant part of the problem is a profound gap in awareness. This is not just a feeling, the data proves it. Recent surveys show that a shocking 44% of women do not know that heart disease is their single greatest health risk. This means nearly half of all women are walking around unaware of their #1 killer. This lack of knowledge has serious consequences. It directly influences how women interact with the healthcare system. It also shapes how they interpret their own bodies. When you do not know what to look for, you are far less likely to find it, or even to search for it in the first place. This awareness gap leads directly to a communication gap. Most women do not proactively discuss heart health with their physicians. Doctors are busy, and without a patient's specific complaint, they may focus on more routine checkup items. This passive approach means critical opportunities for prevention and early detection are missed. A simple conversation about family history, a simple conversation about lifestyle, a simple conversation about subtle symptoms could be a lifesaver, but it is a conversation that is not happening. Even when women do suspect something is wrong, there is a powerful hesitation to act. Fear and a tendency to downplay their own symptoms get in the way. In women, different symptoms can cause deadly delays. One of the most dangerous aspects of heart disease in women is that the symptoms can be very different from what we expect. We have all seen the classic Hollywood heart attack in movies. A man suddenly clutches his chest, pain that radiates down his left arm. While this can happen to women, it is definitely not how it always happens. In fact, up to 42% of women who have a heart attack report experiencing no chest pain at all. This is a critical point. The absence of chest pain does not mean the heart is fine. It means we have to look for other, more subtle clues. These atypical symptoms are often vague and easy to dismiss. They can be mistaken for the flu, acid reflux, stress, the exhaustion of daily life. The most common sign for women is not chest pain, but unusual shortness of breath, which occurs in about 63% of cases. Another major sign is profound weakness or fatigue, reported by about 55% of women. Dizziness, lightheadedness, feeling faint, about 44%. These are not small numbers, they represent the majority of experiences. Around 40% of women experience a cold sweat. About 39% report nausea, indigestion that feels different from a typical stomachache. Many women, about 36%, feel a sense of overwhelming anxiety, have trouble sleeping in the days or weeks leading up to a heart attack. And instead of direct chest pain, about 35% feel discomfort in other areas: neck, the jaw, the upper back, the shoulder blades. Because these symptoms are so easily misinterpreted, both by patients and sometimes by doctors, critical time is lost. On average, Women wait about 37 minutes longer than men in the emergency room before they receive an evaluation and treatment for a heart attack. The differences in heart disease between men and women go deeper than just symptoms. There are specific cardiac conditions far more common in women and harder to diagnose with standard tests. One of these is MNOCA. MNOCA, myocardial infarction with non-obstructive coronary arteries. Signs of a heart attack but no major blockage on angiogram. MNOCA accounts for 5 to 15% of heart attacks and is more common in women. Another condition is coronary microvascular disease, MVD. MVD affects the heart's smallest arteries. These tiny vessels branch from the main coronaries and deliver oxygen-rich blood. In MVD, the small vessels spasm or fail to open, starving the heart. The arteries are too small to see on a standard angiogram, so MVD can be missed. Women are about 2.5 times more likely than men to have MVD. A particularly alarming condition is SCAD. SCAD is a sudden tear in the coronary artery wall, not plaque. Blood seeps between artery wall layers, creating a blockage and triggering a heart attack. SCAD is a leading cause of heart attacks in younger women, up to 35% under 50. Over 90% of people who experience SCAD are women, many with few traditional risk factors. MNOCA, MVD, and SCAD present huge challenges for diagnosis and treatment. They often require advanced testing like cardiac MRI or specialized functional tests. These tests are not always performed, so women can be misdiagnosed. A woman might be sent home from the ER labeled anxious or told it's indigestion, even with a real heart problem. Doctors need to think beyond plaque-filled arteries when women present with heart symptoms. While some risk factors for heart disease are the same for everyone, like high cholesterol and high blood pressure, others have a much greater impact on women. Diabetes is a prime example. Having diabetes significantly increases the risk of heart disease for both men and women, but the effect is much stronger in women. A woman with diabetes has a 44% greater risk of developing coronary heart disease than a man with diabetes. Smoking is another example. It poses a higher relative risk for heart attack in women compared to men, especially in younger age groups. A woman's unique life journey, particularly related to pregnancy, can also reveal future heart risks. Complications during pregnancy can signal future trouble. For instance, developing preeclampsia, a condition involving high blood pressure during pregnancy, can double a woman's lifetime risk for heart disease and stroke. The same is true for gestational diabetes. These are not temporary problems that vanish after delivery. They are powerful warning signs that a woman has an underlying predisposition to cardiovascular issues, and she needs to be monitored more closely for the rest of her life. Hormones shape a woman's cardiovascular story. Before menopause, estrogen helps keep blood vessels flexible, support healthy cholesterol balance, and calms inflammation. As estrogen declines in perimenopause and after menopause, blood pressure often rises, LDL creeps up, HDL can fall, and arteries stiffen. The risk curve bends upward, quietly. This is why timing matters. The timing hypothesis suggests starting HRT near menopause onset may be safer for the heart than starting many years later. HRT is not a blanket heart shield. It is not prescribed to prevent heart disease. Its primary role is relief of menopausal symptoms like hot flashes and sleep disruption. It may have secondary effects on metabolic health depending on the person and the preparation. The estrogen form matters. Transdermal estrogen like patches, gels, and spray have a lower clotting risk than oral pills. If you have a uterus, pairing estrogen with progesterone protects the lining of your uterus. Local vaginal estrogen treats urogenital symptoms with minimal systemic absorption. HRT isn't for everyone. It may be inappropriate if you've had certain breast cancers, blood clots, stroke, uncontrolled hypertension, or active liver disease. Smoking also increases risk associated with HRT. Advancing age increases risk. Early menopause, surgical removal of the ovaries, and conditions like PCOS shift risk the other way, making heart-aware care urgent. The right path should be individualized. If you're considering HRT, bring your full risk picture. Include your pregnancy history, blood pressure, cholesterol, diabetes status, family history, smoking history, weight, and what symptoms you are experiencing. Ask about baseline screening before starting HRT. Use the lowest effective dose. Try to start with transdermal options. Duration of therapy is also important, and regular reassessment. If HRT isn't right for you, discuss non-hormonal therapies and lifestyle strategies that move cardiovascular risk. Your hormones change, your heart listens. Make sure your care plan does too. Your heart, your voice. A call to action. We must reframe the story of heart disease in women. It is not always loud and dramatic. It is often quiet. It is often subtle. It is often easily hidden. The most important message is this: the absence of crushing chest pain does not mean you are safe. Your body sends other signals. We have to learn to listen to them. Pay close attention to changes in your energy. Pay close attention to changes in your breathing. Do not ignore new or unusual fatigue that you cannot explain. Do not dismiss shortness of breath while doing simple tasks. A strange, aching discomfort in your jaw, neck, or back. These could be the whispers of your heart asking for help. When you notice these changes, you must act. Do not wait. Do not explain it away. Tell a friend, family member, or partner what you are feeling. And most importantly, tell a doctor. When you seek help, be your own best advocate. Speak up clearly and confidently. Do not let anyone, including a medical professional, dismiss your concerns. Say, "I am worried about my heart." Ask for specific tests if you are concerned. Ask to see a cardiologist if your symptoms persist or if you have known risk factors. Make your heart health a non-negotiable priority in your life. We see pink ribbons for breast cancer awareness, which is vital, but we see far less for the red dress, the symbol for women's heart health. The disconnect between the reality of the threat and the perception of it is dangerous. When women believe their biggest risk is something else, they may not pay attention to the signs and symptoms of heart trouble. They might dismiss fatigue as just a normal part of a busy life. They might attribute shortness of breath to being out of shape. This lack of awareness prevents women from having important conversations with their doctors. It stops them from advocating for their own health. The first step in fighting any enemy is knowing it exists. For too many women, their deadliest enemy remains an unknown stranger. We must begin to change this narrative. The idea that heart disease is primarily a man's disease is an outdated and harmful myth. While men do suffer from heart disease, it does not spare women. In fact, since 1984, more women than men have died each year from heart disease. The danger is real, it is present, and it affects women of all ages and backgrounds. Understanding this simple, powerful fact is the foundation for saving lives. We have to start talking about women's heart health openly, honestly, and frequently. We have to make this silent epidemic a topic of daily conversation. Heart disease in women is not rare, not unusual, and not benign. It is common, frequently subtle, and often missed. If you found this helpful, subscribe for more evidence-based medical insights designed to help you better understand your health.